Okay, welcome back. If I could invite you to take your seats. We're going to continue with the program this evening. We're very fortunate to have a number of community organizations represented. This segment, as you may have noticed in the film was made back in 2018, 2019, right before COVID, 2019. And so, at that point, everything was impacted by COVID, but we were seeing those impacts even earlier before that. I want to acknowledge and give a special thanks to Kate McGrath, who Kate started with us as a recovery coach, social work intern, MSW intern, and now is working as a clinician in the community, continuing the work. And she was significant in helping with the film. But for this segment, as we talked about in the film, there are gaps in the large systems. There have been always. It's challenging when you have a large system to be able to stay focused on individual needs and individual responses, and that flexibility and the adaptability that all of us need when we're trying to improve our quality of life, access care that works for us. So we're very fortunate. I was really excited. The timing of this is that the Massachusetts State, the Department of Mental Health, and the State Department of Public Health had just launching 2 new initiatives, which I'm hoping, and I really truly believe, will be a great benefit and fill some of those gaps. So I'm gonna introduce the panelists by topic and by agency, and then there'll be time for question and answers. And please take this opportunity. This is a time where you have these professionals sitting in front of you. We usually, don't get to talk one-on-one with them. So really use this opportunity to ask questions. There's no wrong question. If you're curious about something or always wondered about something, this is the opportunity to get more information as we continue to try to address the larger needs of the community. So with that, we're very happy to have with us Joan Taglieri. Joan is the Director of Psychiatry for the Cambridge Health Alliance. And with her is Whitman. Anne is a person with lived experience with mental health and substance use disorder. She's also a consultant for MGH and CHA and BMC. And she consults with all of those large systems on their peer initiatives, how to integrate peer supports into those systems. So with that, I'm going to turn it over to Joan and ask her to share a little bit more about the community behavioral health centers coming.
Thank you. I'm so happy to be here tonight, and I thought that was a great documentary and hope we can get to use it for some other audiences, certainly at CHA. So thanks everybody for that. Cambridge Health Alliance, we were fortunate to have been awarded one of the community behavioral health programs, one of 25 that the state has awarded, and CHA in January becomes responsible for providing community behavioral health center services for the cities of Cambridge, Somerville, Malden, Everett, and Medford. And what comes with that is a major, I think, change in our system of care. 7-day-a-week walk-in and urgent care center that will be in Cambridge. We're also hoping to establish a second one in Malden in 2023. And this is a place that is an open door. So someone who feels the need to access behavioral health services can walk in. They don't have to wait till they're in urgent need. They can walk in, they will be seen, evaluated to understand best what that need might be, and treatment can be initiated immediately or arranged for some specialty care. And so it gives a major, major alternative to what really has been the most accessible for people with behavioral health problems, and that is an emergency department. So where can you go without an appointment, anytime, any day, and you're going to be seen regardless of insurance, correct? And you're going to have an evaluation and hopefully some treatment. We know how badly with COVID, how badly the situation has been in hospital emergency departments, where great overcrowding, for a couple of reasons. One, I think with COVID, we know that there's been a significant increase in behavioral health problems. And so, again, people need access. And so emergency departments become the most accessible. And they're the wrong place for most people. It can be a traumatic just having to be in an ED and having to wait long, long hours. If that's what's needed, that level of care, that's the right place. But for most people, that is not what's needed. They need a place that they can walk in without an appointment and really have the kind of staffing and support really to be able to talk and address their issues. And when I say behavioral health, I'm talking both addiction and psychiatric illness. And so again, 7-day-a-week access, an open door. The person decides themselves that they have a need and that they need to talk to someone. And I think that's a major change. And again, this is going to be statewide. And again, I think CHA is feeling very fortunate to have been chosen to be the provider in this area. And so again, the staff at that front door, they're behavioral health staff. They're going to be a multidisciplinary staff, so you're going to have prescribers, psychiatrists, nurse practitioners, psychiatric nurse practitioners. You're going to have social workers. You're going to have licensed mental health counselors, but you're also going to have people with lived experience there as well. And that's a big change, and I'll just stop for a minute and let Ian tell you about that.
Yeah, I'm really excited that recovery coaches and peer specialists will be integrated into the team and available, and it makes such a difference when you come to an emergency room or an outpatient to be able to talk to someone who's been through it before. And I just think it's going to be really wonderful. I'm going to be responsible with Joan for selecting the recovery coaches and peer specialists, so I'm just making this a job announcement here. You know, the jobs are listed on the Cambridge Health Alliance website. I'm going to be involved in training and running a support group for the peer specialists and recovery coaches as they navigate the systems. And, you know, one of the major issues is having them successfully integrated and taken seriously by the team. And we're going to work very hard to have a cohesive team. I'm also excited that you'll be able to get medical screenings and integrated care because the system has been broken and it's been really hard to get care for mental health and physical health and substance abuse, and I think this is going to be a bright light. And just to end with an anecdote, many years ago I was drinking and I had a mental health issue, and I called the Cambridge Somerville Police and asked they come to my house because I felt my phone was being wiretapped and bugged. And they came and they said, well, this is a phone company problem. You need to call the phone company. And so I called the phone company, and they told me the phone was in my husband's name. So, you know, hopefully this time the Cambridge Somerville Police would come and say, would you like to talk to someone about this? And they could bring in a peer or take me to the Cambridge Health Alliance. And, my issue escalated many years because that initial intervention, which could have been helped by the police and something like the Cambridge Health Alliance, didn't happen. So I'm very optimistic.
Thank you, Ann and Joan. So we're going to move next to, many of you may have heard about the new 988 system. It's really not new, right? It's been in existence for quite some time in Massachusetts. It's the 24-hour, 7-day-a-week hotlines. And we're fortunate to have Eileen Davis, who is the director of the Massachusetts 211 line, as well as the call to talk line. So I'm going to turn it over to Eileen in a second. And with Eileen on this topic is Monica Luke. Monica is a Somerville resident. She is a mental health advocate. She has started her own foundation to assist people with financial resources to get the care that they need, as well as a NAMI board member and other things. So we're going to learn a little bit more about 211 call to talk under that umbrella of 988. Eileen?
Thank you so much. So I think it's pretty safe to say that most people in this room, if they're looking to get some milk, they would pretty much know where to go. If you're looking to pick up a prescription, you pretty much know I passed a CVS right here on the corner. It's pretty clear. Sometimes navigating what to do when you're feeling sort of isolated or alone or despondent, maybe not upset enough to do something about it, like go to your community behavioral health center or go to the ED or even call your doctor, but you don't really want to burden your friends or your family. You sort of are with that, and then you sit with that, and then that escalates, and that gets worse, and that becomes overwhelming until perhaps you're having suicidal thoughts or thoughts of self-injury, or it can exacerbate. So what we hope with the 988 number, in 2020, the federal government passed legislation to turn what was a 10-digit dialing number for suicide prevention and mental health 24-hour service become more accessible by creating a 3-digit number. And they decided to call it 988, okay, 988, and it was launched just this past July 16th. It's really, like was mentioned, the same service that's been in existence for quite some time, since the earlier 2000s, but it's easy to remember, easily accessible, and it's the former Suicide Prevention Lifeline. It's now called 988 Crisis Lifeline. But honestly, we are happy to talk to you in crisis. Trained professional staff, a combination hybrid of volunteers or paid staff. They're all trained the same exact way. Answer the calls 24/7, just about in any language possible. We have the capacity to do that. In the snow, in the holidays, in the nicest days of the summer, are available all the time to answer the call with a minimal wait time. But will absolutely be there to help you in a crisis, or again, in coming January, maybe refer you to the behavioral health community centers, connect you with your local emergency service provider, which was in the video, in cases that are appropriate, your local police. But more times than not, those are like maybe 2% of the time. What we're really there to do is really talk to that person that you might know, a friend of yours, a coworker, a family member, a neighbor, when their feelings are like here, before they get to here, because that's what's keeping our communities suicide safer, emotionally healthier, mentally well. So I'm just impressed. You always, the courteous thing to do is to thank your host and to thank the local police and to thank the person that invited you. But I really want to thank all of you in the middle of the week, staying up kind of late, whatever you're doing during the day, like to come out and learn about these things, because, with what all of us are saying, if you remember one thing one of us says, and you remember 988 or 211 or that The behavioral health roadmap is coming in January. Those are really important information that you never know when you're going to be forced into. It's like when your friend says, "Oh, I'm going to buy such and such a new car," and you're like, "What? I've never even heard of that car." And the next day, all you see is that car on the road. It's like tomorrow, someone's going to fall into your orbit, and you're going to say, "Have you ever heard of 988? You know, they're available. You can call them." So if we leave you with something like that, with all the other resources you're hearing about, including what you heard about in the video, I applaud you all for coming out and doing that, because you're the real heroes tonight, really.
I also want to thank everybody, and I want to thank Patty for inviting me to be here, all of you for coming out, and I want to say that the movie was really impressive. And I have a slightly different view of some parts of this, and I think the movie did a really great job of talking about how fragmented the system is today and the evolution of how 988 as it stands today and the behavioral health roadmap and the CBHCs and the behavioral health line. As an advocate, what I want to see is those building together to take away those fragments so that when you call, you have a seamless experience, right? You call 988 and get whatever it is you need. If it's a conversation that leads you to make a plan that has you go to the urgent care clinic at CHA or another CBHC, that's great. If the plan you need is, I don't know, go to a peer respite, they'll help you do that. If the plan you need is to activate something that's already in your toolkit, maybe meditation really helps you a lot and you forgot to use that. You know, calling 988 is almost will be like a telehealth appointment where you sort of work through what's going on with you. What was the line in the movie? Not what's the matter with you, what matters to you. That's the conversation that we want to move to over time. And the call centers that are doing that across the country already are clearing as many as 96% of their phone calls on the phone, helping people make a plan for themselves and execute that plan. Sometimes, in some places in the country, that includes doing something magical like an outpatient appointment, which just amazes me. And we are a long way from that, but that's the fragmentation. That's what we're looking at here. We have all the resources. Massachusetts has so many resources. Somebody said to me this week, we almost have too many resources, but they're not connected to each other. So if we can get to the point where calling 988, we have 96% of the people figure out what works for them, get connected, great. Then the next level is you need someone to come to you. Those are mobile crisis teams, which is very much like our current ESPs, except they're insurance agnostic. They don't care who your insurance is. All of this does not care what your insurance is. And that's the reality actually today in Massachusetts. Everything about this is fully funded from a combination of federal funds from the feds, like at SAMHSA, but also the Commonwealth has a behavioral health trust fund that just got passed as part of the budget this year that's going to be funded by insurance companies to help support, and that one of the reasons people call the police is the first question isn't, what's your insurance? The first question is, what do you need, right? Well, it's when you call 988, the first question isn't going to be, what's your insurance? And if you need a mobile crisis team, no one's going to ask you what your insurance is. And I think of these mobile crisis teams as getting there and helping you make the plan because you kind of needed somebody right in front of you to help you make that plan. Sometimes somebody on the phone's not quite enough. Or they might take you to the new Middlesex Restoration Center that's coming, or they might take you to CBHCs. They might take you to a peer respite again, or a living room, or a recovery center. What do you need in that moment is what the job is. And for those who need someplace to go, Joan said it well, no one needs to be in an emergency room. Emergency rooms are places where the staff is not really trained or prepared for this kind of problem. They're trained to either treat and release or treat and hospitalize. So if they don't know how to treat you, they say, oh, you need a hospital bed. And maybe you don't. Maybe you need something else. And so there's going to be crisis stabilization units, I think, as part of the CBHCs as well, which are places that folks can stay for up to 72 hours. You're in a Barker lounge. You're not behind a locked ward. and you have clinical staff, peer support specialists, folks like that, helping you make your plan. There's a recurring theme here, right? Getting you connected to the services that you want, because that's what makes it sticky. If it's your answer for you and for what's going on with you, then you will actually go back and use that service. If it's not what you wanted for yourself, if it's what somebody else told you you needed, you may not stick with it, right? We all do that. Well, my father used to tell me when to go get my hair cut, and I said no. So telling people what to do doesn't generally work, right? So that's the beauty of the vision, and I think one of the things that jumped out at me in the video that I want to call out is that Somerville did a beautiful thing by doing a community-based stakeholder combination. So the mobile crisis teams and the places to go have to be geographically local, and you really need that kind of community engagement that talks about what does our community want and need, and how do we do this together. And there's absolutely a place for the police in that conversation. There's absolutely a place where the police are going to be needed, but they're always going to get called. We need to figure out how to collaborate effectively, and Somerville has also done an amazing thing of figuring out, when do we need to call Patty's team and when do we need to go, right? We need that in all our communities, and 988 is the opportunity to make that happen.
Eileen and Monica, thank you so much. We'll be coming back to you. Our next panelist is with Jan Kauffman. Jan is the Vice President of North Charles Impact, and also a consultant to Cambridge Health Alliance, Harvard Medical School as well. So I'm going to turn it over to Jan to just talk a little bit about what she does.
Hi, thanks so much, Patty. First of all, it's a pleasure to be part of this panel and to listen to all of the components that we have in our communities. I've been fortunate to work in the communities of Cambridge and Somerville since the beginning of my career. And I actually started in North Charles, actually grew out of Cambridge, what was Cambridge Hospital at the time, Cambridge City Hospital at the time. I'm dating myself, in the early 1970s. And it was out of that where we began the first opioid treatment program for folks in the community who had chronic and relapsing opioid dependence. In those days, it was heroin. Today, it is fentanyl and all combinations of both opiates and other drugs. Actually, the other thing that I've had the privilege is working with people with learned experience my entire career. In fact, a mentor of mine told me very early on that patients are your best teachers. And that's exactly right. I mean, I've learned so much from community members with lived experience, and I'm so grateful that you are now intricate part of our team. It's been something that's been missing for a very long time, so it's so cool. What do I do? I have two different roles. At North Charles, I oversee the addiction treatment programs. As I said, it was the methadone program that started at Cambridge Health Alliance in the early 1970s, and then North Charles is a private nonprofit that emerged out of Cambridge Hospital because at the time we needed a vehicle to be able to accept federal and state funds. And so that's really how North Charles started. And then, different programs, some were funded at North Charles, some with Cambridge Hospital, that then became Cambridge Health Alliance, and many, many years later. The services that we offer, the clinic is actually located at the Cambridge Hospital on the first floor of the Cahill building, and that's where we administer medication. We administer it every morning, 7 days a week, 365 days a year, and our patients come there daily to receive their medication. Once they are stable and able to manage medication, they're eligible for take-home meds. There are all kinds of federal and state rules that determine how and under what circumstances we can provide those medications. But along with medications is the provision of comprehensive counseling services. So we make sure when patients walk in the door, many of them don't have insurance, to make sure that they get the resources that we need. And that's one of the many, many ways in which Cambridge Health Alliance is really helpful to us and helps us link folks to get the kind of insurance that they need. But we also are fortunate to have grants from the Department of Public Health. So if somebody comes in the door and they have no resources, we can take them into treatment. So it is not a barrier for admission to treatment. Methadone treatment services, and you saw on the film, it's sort of weird to see myself on a film, but nonetheless, a lot of the services are a kind of a bundled deal, so that patients get individual and group counseling. Actually, one of the things that's been really a challenge with COVID is not really being able to provide the group counseling that we've been able to provide historically. And our counseling services are located in a different location in Cambridge, so on Washburn Ave in Cambridge. So when somebody comes to get services for us, they get assessments and diagnosis and linkage to primary care. We're often referring patients, in fact, most of the time, to Cambridge Health Alliance to get primary care. We take people from all over the communities. We prioritize to Cambridge Health Alliance patients, but also to Cambridge and Somerville and the surrounding communities. But there's no person from a community that we would say no to because of where they live or what their insurance status is or any of that. They have to be able to meet outpatient level of care, which of course is important, but when they don't, we really are able to link them to the kind of services that they need. I think that what some of my colleagues have said is that, what's really important is matching treatment to the kinds of things that your patient is willing to have, views themselves as needing. Sometimes what people want is not what they need. And the process of helping somebody get to that place, I think is really important because you have to respect, really how they view themselves and what their backgrounds have been and, how that, helps shape a service that will work for them. I think as folks were saying, if we mandate a service and say this is what you must have, most of us would say, not so much. I think that really making sure that people are connected to what they need is important. I'm really excited about, and my other role is Director of Addictions Consultation at Cambridge Health Alliance. So I've worked in a lot of different capacity throughout Cambridge Health Alliance, integrating addiction treatment services into primary care. And so it provides access to patients who would prefer to see their primary care doctor and talk about those problems. Some people won't come to a clinic, and there are all kinds of complicated reasons for that. So, my role is involved in a lot of that. I also have the privilege of being able to provide training for medical students, residents, family medicine residents, psychiatry residents. We have an addiction psychiatry fellowship program, and we're about to launch a family medicine addiction fellowship. So we have an opportunity to train our young and upcoming physicians about really how to identify and to provide care for folks who have substance use disorders. I think what was stunning to me, and I do some national work as well, but what's stunning to me is to know that only 8% of medical schools actually provide training around addictive disorders. That's pretty shocking. And so it's really exciting to be a part of institutions that are really very active in providing training. And our folks with lived experience are the most powerful teachers. I mean, I've had a lot of experience really taking folks to medical school classes and having them teach the medical students about what it's like to live with a substance use disorder, what their experience has been, what has helped them, what hasn't helped them, you know, that kind of thing. I've also, through Patty, had the privilege of being able to be part of the CT training, so I've had a chance to meet with many of the police officers and fire department, and it's just been such an exciting experience because when I first started to do this work, nobody wanted to hear it or learn about addictive disorders. Now people really want to learn about it, and for me it's so refreshing. It's like, oh my God, they want to hear what I have to offer. And it's exciting, and to watch people really grow and develop and to be able to carry the mission and to carry the skill set into the community is just really very heartwarming for me. And I've also had the privilege to see so many people attain recovery, really sustained recovery. And I think that one of the areas that is the most misunderstood is medication-assisted treatment. Methadone treatment, buprenorphine treatment, using medications as an important part of a treatment plan. I think a lot of times our patients can suffer from stigma and are saying, oh, they're just replacing one drug for another. In fact, that's not the case, and I talk to patients about the fact there are drugs that you get on the street, and then there's medications that are prescribed by your healthcare providers. There's a big difference. And really learning how to use medication in conjunction with psychosocial services is really an important part of it. So I could go on, and I won't, but thank you so much for allowing me to be a part of this panel and be a part of this initiative. It's just really exciting. Thanks.
Thank you, Jan. Really appreciate it. And last but not least, as you've heard and as you saw at the end of the film, we have many, many partners in this work. And it was really exciting when I began to learn more about what the Somerville Police Department does. I kind of always joke, I started at the health department in Somerville. In 2008, my role was like the clinical youth specialist, and my role was to be a resource for mental health in the community and talk to people. And I was so excited to do that and work with schools, and no one came to see me. It was very sad. And when people did come to see me or were referred to me, they were referred by a great friend or family member who said, "Please, Patty, don't tell them I told you that. And please don't mention that they're having problems with this." And I was like, okay, so it's nice to meet you. I hear that you might, have some things that you might need support with. And they'd be like, no, I'm good. Yeah, thanks so much. And I was like, okay, well, here's my number. And I would never hear from people again. And then I started working with the Somerville Police Department. And I was so impressed. Like many people, my only interaction with the police, I tend to have a lead foot. Don't ask my family members. And so, of course, right, it wasn't pleasant. It wasn't a good experience. I got out of some ticket. No, just kidding. But then I started to read the reports and really understand the work that the officers were doing and really see them as members of the community. They are not separate from the community. They are part of the community. And so I've really been privileged to get to know the officers in the department and work with them. And I'm going to turn it over to Captain Donovan, who hopefully will agree with how wonderful it's been to meet me. But Captain Donovan is a longtime member of the Somerville Police Department, came up through the ranks, and he is currently the director of patrol operations, so oversees all of those officers who are on the front line, out on the streets. And then you may recognize a star sitting next to him. Officer Mark McLaughlin is a Somerville born and raised young person. Mark is now a police officer. He's been with the department for 5 years, and he's really active in some of our outreach programs. So at this time, I'm going to turn it over to Captain Donovan.
Good evening. She is so afraid of what I'm going to say. I'm Jim Donovan, like Patty said, almost 22 years with the department. I've been a member of every unit within the department with the exception of traffic, so I never got to meet Patty on the roads, thank God. But I have been with the department for over 20 years, and I have the unique, I want to say opportunity, but I have the unique experience. And when I started 20 years ago, it was the beginning of the opioid crisis for the most part. So I saw the beginning of it, and I saw it work its way through our community, work its way through Mark's community at the high school. It really hit our high school hard. We can go on. Mark could probably give you a dozen names of friends, brothers, friends who've lost their lives. So I personally couldn't even imagine where we would be without the COHR program. I almost want to ask Patty to leave because I'm going to say a lot of good things about the COHR program. But they're embedded in our department. When they came here, we always asked Patty, I stopped into Patty's office frequently, and we always asked Patty, I said, what did you think of the police when you first got here? When you came in with this preconceived notion of us? And she never wants to answer the question. But historically, police departments are slow to change. We resist change. Why is that? I couldn't tell you. Probably should be a study at Harvard someday. But we do resist change. So it couldn't have been easy for Patty and her team to integrate themselves in our department. And it probably took a little while. But I can tell you right now, Patty is part of our family. They are integrated within our department. Like our 911 operators, like our officers, like our other civilian staff, we have the COHR program. And it may sound crazy, but the big thing about the COHR program is geography. And by that, I mean where they're located, like physically where their offices are. Officers are constantly stopping into Patty's office, recommending this or telling her about this, although they've read our reports. Patty and her team have access to all our reports, except for probably a small portion that are legally restricted. But Patty's access to all our reports. So even the officers don't communicate that, which is probably rare. Patty and her staff and her team are already reading those reports, reaching out to my officers. Like Patty said, I'm in charge of patrol operations now, which is basically all the men and women you see out in the road patrolling every day. They are the first ones to encounter someone in crisis. They are the first people. And they are trained, 70% of our department now, 80? I brag about 70 to 80% of our department is CIT trained. So the likelihood of you getting a CIT officer, a CIT trained officer by Patty and her staff is 80%. It's amazing. I would challenge any other police department in the state to be that high. We're a regional trainer now. If you don't remember, it used to be Somerville, right? When I was growing up, a tough community. If you had told us we'd be a regional trainer for something, no way would I believe you. We are the regional trainer for CIT. We train Boston Police Department, the largest police department in the state, in CIT. We train Cambridge, right? Lord knows we train Somerville is training Cambridge. But that's because of Patty and her staff. They are, when I say embedded within our police department, they are embedded within our police department. We communicate with them on a daily basis. And what Patty has said and what retired Chief Fallon says, we're the first ones out there in the community. We're meeting people in the community. We're the boots on the ground. And the culture change in our police department is we're not going to arrest our way out of any solution. We're really not. It's not arresting your way out of the drug problem in this country or this city or this state. It's change. It's collaborating with other departments to find a solution. And then, like what Mark said in the film, there are cracks, right? And we land here, we go over here, we fall through that crack. And ultimately, when they fall all the way through, it's us. And to have that training that Patty's provided us, and have Patty as a resource to reach out to our community, I can't put enough on it. And even beyond that, Patty's become almost a counselor to some officers in the department. I know that I've on occasion stopped in when I've wanted to, basically kill. Is this recorded? Kill one of my 4 sons. And Patty talks me off that ledge, and she goes, "Well, what about this? What about that?" And just providing officers with that resource, because what people don't realize, we're not animatrons, we're not robots, we're people. We bring to our employment and we bring to our work every day marital problems, mental health problems, depression, financial problems, and having Patty and her staff there is for us to when we see in ourselves the people we see in the people we deal with ourselves, and to have Patty and her staff there to help us kind of guide us through that is invaluable. And I truly don't know where we would be without them. It's a resource like no other. And I can't, when I look at the list of police departments, I can't believe that every police department is on that list. I really can't, even from the smallest police departments to the largest ones. And just in closing, they mentioned in the film about one of the people who used to call the police department all the time. She's been calling the police department since I started in 1999, 2000. I can't say her name. But my 911 operators would get on the phone with her and talk to her for hours. Like, our 911 operators are like, clinical psychologists. They really, truly are, if you listen to their phone calls with some people. And they'll talk for hours when they can. But that one person who called, she's been calling, forever and a day. And when they said, I don't know who thought the idea of cutting coupons. Cheryl, you want to raise your hand? Cheryl saved 911 probably 10,000 phone calls. But it's something simple as that, right? Would an officer think of that? No, we wouldn't. Nor do we have the time to spend the time and effort with that person. But again, it's a resource, and it's a resource we can't do without. And like I said, being embedded in the police department, something simple as being in our lobby. Because an officer walks in that lobby after working the overnight shift and had dealt with John Smith or Jane Smith, he knows that he can turn to Cheryl or Patty or someone in her staff and say, hey, this is what I dealt with last night. This is where we are with it. And, and Patty like, okay, we'll follow up on that. And then they'll include us back in on it and, key us in. Just in closing, I could talk Patty stories and COHR stories all night, but it's not unheard of for me to be at home at 6 o'clock at night to be on the phone with Patty discussing something or basically yelling at her. And just one last story, Patty's story, and I gave it to Mark. But Patty had said to me, can you come to this film we're having? I'm like, absolutely, no problem. I'm going to go to rearrange my kid's sports schedule and I'll be there. So I put it on our calendar at home so my wife knows that I'm not available tonight. And she goes, you're a panelist. I said, what? She goes, no, you're a panelist. I said, what do you mean? She said, the core thing, I looked it up and you're on the panel. And I'm like, I'm going to kill her. But I truly, like you said, the citizens of Somerville are so well served and better served by the police department because of Patty and her staff. And if everyone just wants to give her, her and her staff an applause, because, like I said, every community needs a Patty and a staff like that. Truly, I mean it.
Thank you, Captain, and I second that. Well, first I just want to say how excited I am for these developments and how much they're needed, and you can bet that SPD will be your largest referrer to these programs, because that's really what our community needs. And I know the emergency rooms are sick of us, so this is absolutely, what is needed is low barrier wraparound services. So a bit about myself, prior to becoming a police officer, as they mentioned, I grew up in an interesting era in Somerville at the beginnings of the opioid epidemic, and, just a lot of other things. It was kind of a spike in gang violence, and we also had the youth suicide epidemic at the time while I was at the high school, and that led me to get involved in the community and doing community work at a young age, and later led to me. I found myself working at the homeless youth agency, doing street outreach. So I then became more involved in helping, doing that work in the community of finding people beds for detoxes or mental health services, and learning how to de-escalate people in crisis. And at that stage, seeing the lack of resources and how challenging it was to get people help. And later on, I became a police officer after doing that for about 8 years. And seeing that, a really exciting time in policing, and specifically in Somerville, where the policing was changing, and there was talk about, moving towards this direction of, finding people help, and, that criminalizing things wasn't necessary, as the captain said. We're not going to arrest our way out of this, and that was something that really appealed to me. I was lucky enough to have some mentors that I wasn't someone that grew up saying, "Oh, I want to be a cop," and that's a lifelong dream. I kind of meandered my way and found, and finally, the job became very appealing to me to see that. I was like, all these skill sets I have working in the streets of Boston, being down Methadone Mile and doing this is actually perfect. Like, this is the perfect place and that perfect access point. So I was lucky enough to join the Somerville Police Department when, Patty and, the core unit and everyone had already kind of started laying that foundation. I was really excited to jump in and be a part of that. So right now, I've been on for about 5 years, and I'm a patrolman. But one of the other things, I try to expand my role as much as I can. I like to collaborate with Patty as often as possible, and I get also to do, we have an outreach program where we collaborate with Access Health in Cambridge, which is a needle exchange program. And once a week, we'll go out to respond to individuals who have overdosed. And we offer them services. I'll go out with myself and a outreach worker from Access and either Patty or one of her employees, and we show up and we kind of say, hey, we have that conversation where we see that there was an incident here, are you interested in Narcan, getting trained in Narcan, or are you interested in more support services? And this is a really a huge shift in mindset as far as, I think, breaking down barriers in the community between police and the community, and breaking down stigma on both sides, because the police are stigmatized, and as well as people suffering from mental health or addiction are stigmatized. And it's a really fascinating opportunity to traditionally, although state laws have changed to adapt to, specifically the overdose crisis that we find ourselves in, and traditionally, someone with overdose, and they'd worry that they'd wake up and be arrested and they'd be charged with possession, and that, we've moved away from that. But people on the ground living with addiction they're not necessarily keeping up with state law, and they still live with that fear of, let's not call 911. I've had friends who, passed away in snowbanks because the Narcan wasn't available to them, and they didn't want to call 911 because they were afraid they'd be arrested. So it's a fascinating transition to be able to have this conversation with people, show up, to have a cop come to their door, although I'm not in uniform, I dress in plain clothes, and the conversation is, I'm here to offer you services. And we're collaborating with people in the community. And I think, like I said, it breaks down that stigma on both sides, where as officers learning more about treating addiction and mental health in a more way that's advantageous for recovery and long-term recovery. And it's also nice to be able to say, hey, I'm not here. Typically, it's always a bad interaction when you deal with police. And, a lot of people, see that, if we're having bad experiences with police or there's a negative perception, we need to keep people separate, keep them away. So let's make sure they never have to have that interaction. And I think the approach is, not to build walls, but, build bridges, as they say, is, making sure that we're having interactions that are not negative, that we're showing up and saying, hey, I'm not here. My concern right now is not, what crime you've committed. My concern right now is getting you help and offering you services. And as I said in the film, one of the things I really enjoy the most is, we're traditionally seen as the gatekeepers to criminal justice system into the, incarceration. And I really think we're pivoting here in Somerville to being the gatekeepers to resources. And as I said, I guarantee we'll be the #1 referral to these places. These are things that we need, and we need to be able to collaborate. Yes, I will be. I have a lot of questions actually for how the referral system will be working and how we can. I have a list of clients for you, and where I look forward to working together.
Thank you, Mark and Captain Donovan, and thank you all. I know we're a little bit over time, but I do want to encourage people, if you have a question, if you want to just project it out, And to any of the panel members, they'd be happy to respond.
So I'd like to know a little bit more about, I think I understood the CIT program and the training for police and the ongoing support for police with that. I wanted to understand a little bit more about sort of the secret sauce, special sauce with COHR that it talked about in the documentary, that when somebody is identified, there's some sort of triage process about which calls will go to police response and which calls will get COHR response. And it talked about that a high percentage of folks who need service already are connected to some sort of services already.
Yeah.
So what was then the thing that COHR does that helps sort of fill that gap and get people what they need, as opposed to, is it a gap in social work service or?
So it's interesting, and I really appreciate the question. And what the special sauce is Patty, Cheryl, Jen, and all of our interns. But the special sauce really is that low bar access. So when people, we are not, it's not an either or, it's and both with our program. So basically, when we established the unit, it was through a grant from the Department of Mental Health. And at the time, there was a lot of co-response programs, and that's what we're circling back to now. Co-response is the idea of a clinician goes out with an officer, different shifts, and they're always available on scene. What we found was that on those, kind of emergency calls, people are in crisis. They're not really in a place where they want to convey a lot of information and so the state was actually looking for an innovative model, and we said, okay, we can do that. We're going to do a follow-up aftercare. So the magic is that the officers write detailed reports. So we really get a sense of the context of what happened on that emergency call, who was there, who was involved in it. And through that, being within the department, as Captain Donovan said, I have access to all of the reports. So I can really read through and get a little bit more information. As I mentioned earlier, when I got referrals at the health department, it was like, so, can I help you with something? Here now I say, just wanted to follow up. I saw that last night you had a response from the police and that you were concerned about your adult child who struggles with mental illness. It sounds like, they've been having difficulty with their medication. Initially when we call and we say, hi, we're just calling to check in, see how you're doing, everybody's like, oh, good, I'm fine. But then when you say, well, how's your daughter doing? How is your loved one doing? It sounds like you've been really concerned about phone calls that you've been getting. Sounds like, you're not quite, sure where they're coming from. Is that something you'd want to talk about? So it's really that low bar, and as Joan had mentioned with this new center, right, one of the big obstacles, if you've ever called for services, you get an automated system. Dial 1 for this, dial 2 for that, dial 3 for that. By the time they get to 4, I don't even know what I want, right? So, or what the categories are. So it really is that low bar. We don't ask about insurance. We don't say, what are you eligible for? Do you have mental illness or addiction? We're just like, how are you doing? We're just interested in getting to know, how we can support you as a city service. And that's one of the benefits. So.
In one word, the special sauce is relationship. It's the relationship we have with the court department. It's seamless. It really is. And it took a while to get there. Not years, but it took a while to get there. But it's relationship. It's recognizing the value of the Corps. Our officers recognizing the value of the court department. And our officers come in now out of the academy, and that's all they know. And at some point, probably when I leave the department within the next 9 years, 8 months, and 7 days, is every officer basically will have grown up, for lack of a better term, with the court department. They will be, they'll be reliant upon that. There'll be no one there in my generation knowing a day when we didn't have the court department, thank God.
Thank you. Any other questions? Yes.
Well, this isn't a question, it's a satisfied customer report. So I work in an office suite in Union Square, and one day we had a very agitated person come in. He's somebody pretty well known as one of the walking wounded. And he was very agitated, demanding to have this child's iPhone or whatever device recharged. Terrified the staff in the office. He was getting escalating. So a couple of us started pushing him out, not very successfully, into a corridor, and somebody else called the police. Somerville Police, 2 officers came, and they talked him down. I followed them down. They had to go downstairs and down the street, and I watched them go down Somerville Avenue, and I watched this person who had been in extreme distress get calmer and calmer and calmer. I was just so impressed, so thank you.
Thank you.
Thank you. Thank you. Any other questions? Yes.
Yeah, so it's my understanding that this budget year, the Somerville City Council voted to allocate, I think, $200K to an alternative emergency response team. And I'm just wondering if COHR would collaborate, or if you think it would fit with something like that, given that it's an aftercare program, if it could work with a alternative to the police team.
Yeah, so thank you for that question. We would certainly collaborate in, kind of looking at the needs. I don't necessarily see that. I think that, that's been our experience, that an alternative response, a lot of times, and you've heard it tonight, I think, oftentimes we put all of the funding in that crisis response. And what people really need is that follow-up aftercare. So it really is, kind of how is that model? If you're just sending a different people, and there's a big assumption there. Sometimes, and they will tell you, they'd be happy to tell you that sometimes I'll go out on a call with an officer, and they'll be like, who are you? I don't want to talk to a mental health clinician. I'm concerned about my safety, and I want to talk to you. I feel like, there's something wrong in my environment here, and I need a public safety response. So as they said, we don't want to divide. So collaboration, absolutely. It's kind of how you implement it. And that's why I'm really excited for, you saw in the film, we started in 2019, things have changed, we still have a lot of the same problems. But this community behavioral health center is really, we're going to be very kind to them in their process of implementation. But I think that is significantly going to be a world of difference because people don't have those opportunities. You can't get an appointment. Sometimes you can't see a therapist twice. It's kind of that walk-in in the moment. So possibly, absolutely, there's definitely room for multiple services and layers, and we would be happy to collaborate. But I don't know that, we specifically kind of don't want to be that emergency response because it seems like everything gets dumped into the crisis, and you really will find that you'll lose out on that follow-up because you don't have the resources and the funding to do so. So thank you, though. Thank you for that question. Yes?
Thanks to everybody so much for speaking tonight. It's wonderful to hear from everyone, but this is so exciting about the Community Behavioral Health Center. The idea that mental health care or substance abuse care could be freed from insurance is unbelievable. It just sounds like a paradise, I'm wondering how, and it also, it's heartening because some of us remember the closure of the Cambridge Hospital emergency room, the psychiatric emergency room, which was such an important piece in the community. So how will this become not like the Cambridge Hospital psychiatric emergency room? How long will this be around? How are you going to keep it from, the floodgates will be open, people will be, I can't imagine any day that you won't be full of referrals. And how will people access the services?
It's a lot of great questions, so where should I start? We will be getting out to the community in the next couple of months. One of our major jobs is really to get out there, get people information, all through the 5 communities we are to serve, and tell them how to access us, where we are, And so we will be doing, a major campaign. So and it's sorely needed, because as someone mentioned, people don't know where to go. So that's a big one. There are thousands of people across Massachusetts on waiting lists for behavioral health services. Thousands. It's scary, right? And a lot of those people get very sick while they sit there on a waiting list, and they end up in an ED. There's not going to be a miracle on January 1st, but it's the beginning. It's the beginning of a 7-day access, walk-in. You don't have to be urgently in need. We'd rather people come before that happens, but, and again, we'll set it up that there's a staff who can really try to adequately assess the issue, and provide some immediate care. The immediate care is very important, but so is what happens next, right? And so the other part to the CBHC is really to be able to facilitate that access to specialty services. If it's a child, if it's substance use, if it's psychiatric, if it's an elderly person, whatever, part of the job is really facilitating that access, not giving a slip of paper saying, call this person, but actually making it happen. And part of that is following up. So it's not a one and done, like an emergency room, I think someone mentioned. We will follow up with that person, have them come back a few times if needed, to get them to the, to connected to the right service. So it's, get in there, work with the person to understand the needs, and then stick with them for at least a few times to make sure they get connected. So the follow-up is part of the work as well. I'm sorry if I didn't answer all the questions.
I can take the funding. So I also heard you say, how do we know that there's always going to be money for this and it won't just go away because there's no money? The biggest gating factor right now is not money, it's the workforce shortage and being able to staff up to meet the 1,000 people waiting on the waiting list. There's a lot of money coming from the federal government. There's a bill at the federal level that would make that funding permanent. That's called the 988 implementation bill, and it's got bipartisan support right now. So a lot of the advocates are really working hard to get that passed so that the funding is that is flowing to the CBHCs from SAMHSA will continue. And then the Commonwealth has done sort of their own due diligence for supporting the roadmap, which the CBHCs are part of that too, by establishing the Behavioral Health Trust Fund that requires, among other things, a payer surcharge in it every year. And I'm going to trust they know their budget. I have not seen it, so I will just guess that they're right with their $33 million. But people have thought long and hard about the money. So I'm not, as an advocate, I'm not so worried about the money. I'm definitely worried about the workforce.
And another question. Yeah, I have a question about the CBHCs. So if somebody comes in and says they seem like they're in acute crisis, but they want more longer-term therapy or psychiatry, you guys are going to just see them for maybe a few times and then connect them. And why I say this a minute up is because, just for example, Julie and I work a therapist at a mental health agency, and our referral list it's unbearable, right?
Right.
And so.
Not because we wanted to.
Not because we wanted to, or even like the clinician, it's just, there's just a million things, right? And so I'm curious what you guys are gonna do for like clients longer term.
All right, you're so well educated to ask these questions. So it's a shift in how we're gonna try to provide services, to tell you the truth. So the idea is to create better access, hopefully before people get sicker, honestly. And then to really do very focused short-term care. But to include in that care non-clinical people. So peer specialists, case managers, recovery coaches. So so it really expands the workforce in a sense. So if you think about it, how much lands on a clinician in most situations, right? And so that's one of the changes that is sought in this model, is really the team is different. And it's not all about a clinician. It's a multidisciplinary team that really looks to people with lived experience and case managers. As someone said, it's not just a behavioral health illness, it's psychosocial as well, right? And so I think we're trying to round out the team. Yes, the workforce is worrisome. With the pandemic, not only did the need go up, just unbelievably, but the workforce went down. So it's the worst of all possible situations in that sense. But again, let's build the team with people we really didn't well utilize before. And to your point, Monica, the funding. So when there was the psychiatric emergency service, it was a wonderful service. It pretty much went bankrupt in a sense. There was no funding for psychiatric or behavioral health services. I mean, it was very poor. This changes. This whole financial, the reimbursement for services makes a huge change, and it actually allows, instead of, and I'll use this term just because I've been in hospitals a lot in my career, each patient that comes in the door doesn't mean you're losing more money. This changes the whole situation where you actually are going to be able to pay for resources to provide for the patients. It won't happen on January 1st. It's going to take time, there's no doubt about it, to really try to catch up in some way with the need. But and another part of that is really thinking about alternative strategies, using more groups. Group treatment works exceptionally well for certain people with certain illnesses. And I think we don't use it enough. And that allows more people to be served. So it's really trying to think of every single way that we can make services more accessible. And again, more focus, so people don't have to be in care for the rest of their lives, right? They don't have to be in therapy every week for the rest of their, let's really find out what you need, let's focus on it, let's try to get you to a point of, better health, and let's bring in other people who can support you as well ongoing. Does that help?
Yeah, I just think the peer workforce has been underutilized, and there's going to be more reimbursement for it, and that's one of the key factors that helps people continue to recover. So that's going to be a new twist to this community behavioral health center.
Just one more thing to note too. If these are issues that are important to you, just know your candidates that you vote for, and know what their platforms are, and just make sure that they support what you want to see happen for funding.
I'm really glad to be hearing that, about follow-up and relationship. I know that historically, outreach to people who need help hasn't been reimbursable. It's only reimbursable when they come to treatment, and it's still going to be place-based treatment. And I'm wondering whether the outreach and the follow-up and the relationship building will extend to helping people whose commitment to participation is still weak. And so they may need to be visited, and and called, and not necessarily participate in treatment every time they're supposed to, but actually sort of cultivate the relationship so that when they're ready, is that all going to be part of the mix?
this model does not require a person to come in. That mobile is reimbursed, virtual care is reimbursed, and so again, the financial model is one that supports a variety of modalities, actually. And so hopefully, you know, we pick the one that works best for the person. And so it doesn't have to be office-based.
Just on that note too, I hope that with this, I think it is going to be a really significant service that we've been lacking. But I hope that it will continue to be, you know, in partnership with a lot of the community organizations. I know that we have someone from, Fred from the Office of Housing Stability, who has been an essential partner. And that's one of the other, you know, kind of aspects of COHR is that we will go out in the community. There aren't many agencies. We have a lot of agencies that have headlines. We help people with court issues, immigration issues. And then you call them and say, well, can you go to court with this person? And they're like, oh, sorry, we can call them, but we can't go out. Our staff goes out because trauma-informed care is being with that person, right, through their process. And so we'll go and accompany them through court, and it's amazing how you get to know someone as they're, you know, kind of experiencing these challenges. You really broaden your understanding of what their barriers are. And it's significant to understanding then how can we help them. What service is going to be effective and appropriate. So, yeah. So I hope it continues to be a collaboration. Let's not put all the beans in CHA and continue to look at other resources in the community that also need to be supported. I know we're way over. Do we have one last question? Want to have a burning question?
Sorry. Do you know if there are other states that are following this model? And if so, are you networking with them?
I know 988, definitely. So Monica, I'll turn it over to you.
988 is on 3 pillars, basically some place to call, someone to go, and someone to respond and somewhere to go. And there are states across the country that have been doing a lot of this for a long time, and some of it looks like COHR. I think COHR is pretty unique in the integration with the police department, although Cahoots out in Eugene, Oregon does something similar. And so does D.D. Hirsch in LA right now. They're getting most of their phone calls not from 988, but from 911. So, you know, in the places that already have a strong collaboration like Somerville does between the 911 system and teams like COHR, the 988 transition looks a little bit different. But there's at least 4 states in the country that are kind of kicking butt on this. So we have a lot to learn from them.
Great question. On that note, I'm going to conclude. I want to thank you so much for coming out tonight. I hope it was informative. We are right at the police station. They're open 24/7. If you're ever interested or have a question, follow up, please don't hesitate to drop in, come and see us. Thank you again, and thank you for all the panelists' time and partnership.